question. So given the different etiologies of CKD, how do we optimize recruitment for these patient populations and ensure that patients actually have the diagnosis that we think they have and we're identifying them correctly? So I'm throwing these questions out to the panel and you can all just kind of chime in and jump in.
Yeah, I can take that. I mean, at least from the non-dialysis, I think it kind of really hits on that. You know, obviously I work at Biorasi, we're a CRO. So, I mean, when it comes to the patient populations, I think the biomarker discussion is one that needs to be had because, especially with these, you know, pre-dialysis populations, there are so many different subgroups always coming out and subgroups of subgroups. And each one of those has obviously, you know, different etiologies and different biomarkers, and especially when, you know, you're going to sites and trying to optimize recruitment at these sites. And if you're working with, you know, independent sites or small sites, a lot of times the standard of care doesn't include, you know, these biomarker analyses. So they may have the biopsy, but then when they're going back to those patients, a fair number of these, you know, I have spontaneous remission. A fair number of these just never had, you know, the biomarker done. So when you go back and you try to do these biomarker analyses, a lot of times you have this very, very high screen fail rate. So I think that's one of the big challenges on that side of the fence. But what we've done that's been at least helpful in that regard is we've actually kind of done more high throughput pre-screening with basically getting informed consent for just the biomarker analysis, then putting through, you know, all the patients through to see if, you know, if they confirm the diagnosis on that, and then taking the, you know, those few patients, sometimes it's only 10 or 15% of those patients that actually had the confirmatory biomarkers, and then running those through the rest of the screening procedures. That obviously saves a lot of time and money on the screening, but it also just makes sure that you're not putting, you know, a lot of people through, you know, unnecessary screening procedures with their remission, or, you know, if really that they don't have that confirmed disease. And it's just making it a little bit, you know, it's been difficult because, you know, every year, as you guys know, probably the FDA is coming up with new ways that we can assess the disease severities in these pre-dialysis, you know, earlier stage diseases. So. But that's just a couple of things we've been able to do, and I think, like Dr. Gurwal mentioned, you know, just to keep working on getting the biomarkers to get more defined and be able to differentiate between different etiologies a little better is going to be the path forward, because then we could potentially detect, you know, the CKD at earlier stages, and eventually we can hopefully use those same biomarkers for actually, you know, the endpoints, because right now still in phase 3 endpoints, the only ones that are approved are the, you know, 30% or whatever change in GFR and ACR, and those are really only, you know, good for secondary nephropathies. So I think those are some of the things that we've done at Biorasi that's been helpful.